Good morning, everyone. I welcome you all for the doctor's free presentation. Each presenter will have 5 minutes of presentation and 2 minutes of questioning, and you'll be marked on both. I thank the judges, Dr. Ajay Khanna and Dr. Jay Kumar. So we'll be starting with the first presentation. I request Dr. Nandi to give his presentation.
A very good morning to my respected professors, teachers, and all my seniors and colleagues. Myself, Dr. Arnab Nandi, from IPGMR SSKM. You will be presenting today a case of my cases of cystic hygroma of adult onset, a rare entity. Coming from the introduction, cystic hygroma is an aberrant proliferation of lymphatic vessels resulting from abnormal development of lymphatic system. Although it is most commonly seen in the neck, but it is also seen on the axilla and other areas. The definitive cause is not usually known. Most commonly, it is thought to be trauma or upper respiratory tract infection as possible triggering factor. The most interesting fact is that it is most commonly seen in children less than 2 years of age group, but and very rare in adults. Less than 150 cases has been reported till now. And here we are reporting 2 cases which are of adult onset. My first case is a 50-year-old housewife presented with a painless swelling in her right side of the neck. The swelling is insidious in onset and it has increased gradually, no previous history of fever or trauma. On examination, I found that the solitary cystic swelling was of around 8 into 6 centimeter in size. It does not move with deglutition. There is no visible pulsation and no palpable lymph node was present. Then we did investigations as the USG is primary baseline investigation. It shows that a cystic swelling of 8.5 cross 6.2 centimeter with floating echogenic foci and in the right supraclavicular region, no significant lymphadenopathy. During the MRI, it is shown that the cyst is multilobulated and around the same size of 9.7 and 9.3 centimeter, which was hypointense on T1 and hypointense on T2. And FNAC fluid is consistent with cystic of adult onset cystic hygroma. My second case was a 30-year-old housewife who was also presented with painless swelling for around 4 months. The swelling was around 5 into 4 centimeter, and the swelling passes deep to the sternocleidomastoid, fluctuating and free from skin and underlying structure. The swelling also does not move with deglutition. USG shows their similar cystic lesion. CT neck shows that 7 into 4 centimeter cystic as well. There is no septation, no calcification, extended up to the superior mediastinum over the parietic region. And CT chest shows the same thing. Management, both the swelling has been excised, complete excision done, all the important structures preserved, no recurrence and complication till now. After almost it has been 1 year past. The gross pathology was assessed and histopathology confirms the diagnosis. Coming to the discussion, this cystic hygroma actually a congenital malformation, which is mostly present in the less than 2 years of age. But it is so rare in adult because of this paucity of literature makes it a diagnostic challenge. And also it is so that's why often misdiagnosed with other cystic swelling. And there are many other surgical treatment options like sclerotherapy, laser therapy, but surgery we have done in case of adult, which is mostly preferred. And for better outcome till now, it has of no complication, no recurrence. So I think this presentation, this paper will make the literature further improve as there is so much of paucity of literature. So coming to the conclusion, and for optimal management, we are further doing the study. And thank you. These are my references. Sir, late presentation, I can explain. Usually, as it is most commonly congenital, most of the adult late presentation occasionally, usually occurs. Maybe it is a congenital which did not manifest later on. Possibly an upper respiratory tract infection or trauma or any other triggering factor may be presented. But we have thoroughly asked the history and seen that it is not like that late presentation. It is actually an adult onset. So that's why it is so rare and that is of so importance. Yes, sir. Mostly.
You explain it is occurring in the adults.
Sir,
That means the dormant.
yes,
Come out,
yes, yes,
correct?
yes, sir.
It's not an acquired.
Sir,
So you told that the gold standard for treatment,
Hmm.
surgical.
yes, sir.
Do you think without easy to excise in toto, that cystic hygroma?
Sorry, sir.
in what?
Pardon? Pardon me, sir.
Usually the cystic hygroma has a very thin wall.
Yes, sir.
Whatever, even a small movement will rupture.
Yes, sir.
How do you avoid?
Sir, to avoid, we have first thing we have to do is meticulous dissection. Meticulous dissection is the main thing. And all the next main thing is we have to preserve the important structures. That is, as it is usually present in the neck, axilla, which all the important structures are present. So we have to do it meticulously.
Can you think of give some sclerosant?
Yes,
Wait for
sir.
the inflammation.
Yes, sir.
All become thick.
Yes, sir. But sclerosant actually, it is not in all the literatures. It has been shown sclerosant is previously has been given but not preferred because of the sclerosant. There are other important structures which may have caused in
It's not
damage.
the answer. It may be a micro communications.
Exactly,
It is some other-
microcommunication, and also there may be chances of recurrence.
Very good. Thank you.
Thank you, sir. Sir, vascular malformation, we have examined extensively through proper investigation. It is congenital malformation of lymphatic channels, not vascular. Also, the CT scan shows and MRI shows that it is separate from the arterial structures. And
What do you understand by vascular?
sir, vascular means all the vessels, including the artery, venous, and lymphatics. Yes, yes, obviously, sir.
The cystic hygroma is a old term which is not basically
Lymphangioma, lymphatic
Lymphatic
malformation. Yes, sir.
What was your differential diagnosis for this patient?
Sir, my clinical differential diagnosis in this case, maybe there is for adult patient, maybe this case, in this case, there may be cold abscess, or there may be, if the swelling is present in the midline, there may be branchial cyst, thyroglossal cyst. That may be the differential diagnosis, cystic swelling.
One, you said about the resection of this or excision of that.
Yes,
The problem is a thin wall.
yes, sir.
What is the other problem, which is probably the most important problem, which is there in if you are carrying out the excision of this?
Sir, thin wall is there. There are other important structures. Most important problem is recurrence. Complete excision is
Because of what?
because complete excision is not possible. Sometimes
Why?
there
Why
is
it not?
there is some pseudo pods like structure which are extending to the surrounding structures. So remnant of the tissue may be there. So complete recurrence is,
What is rice seed?
yes, sir. I have sorry, sir. I just now I
Telling the pseudopodia which are there.
yes, sir.
That they are entering inside the muscles.
Exactly, sir.
You cannot take them out.
I cannot do.
All things.
Yes, sir.
And
Yes.
that is why the sclerosant is a
Scler-
preferred choice rather than
Okay,
going
sir.
for the direct excision.
Okay, sir. Thank you, sir.
I request the next speaker, Dr. Vijay Kumar.
Good morning, everyone. My name is Dr. Vijay. I'm from Vascular Surgery Ramaya, second year resident. My topic is on last resort and short gap measure on tunnel cuff catheter in the tertiary sector. Coming to the introduction, an AV axis can add months, if not years, to the patient life with who are having end-stage renal disease. And the tunnel cup catheters have been used as an option for the axis in the cases where all options have been exhausted. And the most often patients present with themselves in an advanced uremia for the first time to the nephrologist without any functioning of AVF, maybe the one of the cause. And the catheter use is the prevalent dialysis population has been remaining increasing. And the dialysis outcome at the practice, the pattern studies analyze showed the catheters as a primary vascular axis. It was used 23 to 73% in incidental dialysis patients in several countries. And advantages of tunnel catheters are availability in multiple sites for catheter insertion, and the immediate availability of access providing high blood flow rates of 250 to 300 ml per minute, and having non-hemodynamic consequences like AV fistula is having. And its longevity and low rates of catheter infection is also one of the advantage. These are the KDOQI guidelines for transcatheter transcutaneous tunnel catheters. And there are short-term duration and long-term duration. In short-term, there are AVF was created, but is not ready for the dialysis. And the patient who are having acute transplant rejection and other complications after the transplant may require dialysis for short period. The patients who have complications required for the limited peritoneal rest, like infection in pleural leak, and the patient is having live donor and ready for the transplant. And the patients who are having complications of AV graft, such as major infiltration tissues like cellulitis, to prevent the rest of the fistula. And the long-term duration was for previous failure of the AV axis and patient having a less limited life expectancy, and the absence of all weeks axis was done and it was exhausted. And our aim of the study is to assess the indications of the tunnel catheters and to assess the complication rates and its management. And our methods are, it is a single sector prospective cohort of 48 patients inserted over the period of 2019 September to the 2021 September. And the patients were dialyzed in the hospital in the various peripheral dialysis units which are attached to our institute. Our indications were vascular poor caliber veins. One is time taking for AV fistula maturation, and other cause is the exhaustion of all AV axis, and the other cause is the primary axis to initiate the dialysis in the patient in whom the live donor was available for the renal transplant. Our approach was prior ultrasound of the patient to check the vessel patency of the neck vessels or femoral vessels, and doing ultrasound guided puncture to prevent multiple punctures and collapsing of the vein, and giving prophylactic IV antibiotics to prevent the catheter-related infections. And fluoroscopic guidance was approached to confirm the position of the tip and any kinking or anything. And we are taking a MAC anesthesia backup also to prevent it, to check for any arrhythmias or anything. And in our study, the most common more age was 60 to 70%, and it is equally with 50 to 60 years also. And it is of male of 29% and female of 19%. And the access route, what we mostly use, around 50% is right IGV, and the least was the left femoral access route. And the primary endpoint of the catheter, which is the catheter was out or not working also. The causes of catheter dropout is death is the most common cause. And the patient who have already got a renal transplant, and the patients who are switching to the AVF, and the sepsis of the malfunctioning catheters are account for the catheter removal. And our result, the main age of the patients were around 41 to 60 years. And the most common insertion route was right IJV. And the cause was absence suitable veins. And the mean time of catheter trauma was around 3 months. And the complications, what we noticed in 48 patients, we got a bleeding of 3 patients and sepsis of 1 patient, and having a flash pulmonary edema in patients who are having fistula previously of 2 patients, and having insufficient flow in 1 patient, death in 1 patient. And our catheter dropout in our cases are 2 patients are switched to the AVF, and 1 patient we removed due to sepsis, and 1 patient due to death. This is the thing what we will give to the patients while doing dialysis to prevent the catheter dysfunction by the thrombus or to prevent the fibrin sheath formation. And coming to the conclusion, the complication rates are very low with or lower when compared to the surgical with the fluoroscopic and sonographic guidance. And the prior ultrasound to check the vessel patency and the puncturing the vessel. And we suggest the antimicrobial therapy to be initiated while awaiting blood culture results are there. And use of thrombolytic agent to biologically disrupt the fibrin sheath by giving heparin to the locks, and the checking the position of the catheter tip by, or any kink by the fluoroscopic guidance. And these are my references. Thank you, sir.
What you want to tell the audience?
Sir,
Sperm cath, no?
yes, sir. We want to approach the patient to prevent the catheter-related infections like infectious and non-infectious complications, sir.
What is the purpose of using cuff funnel catheter
Sir,
over the ordinary jugular catheter are subclavian?
Sir, jugular and catheters are having long-term complications like stenosis of the vessels. In tunnel catheter, the tip was flexible and the flow of the blood vessel also not damaging the vein wall.
Oh, good. That also a foreign body will produce all
The
reaction
tip is having in different levels, sir.
Why
The
you want the only tip? What about the sheath?
sheaths.
Whole catheter.
Sir, I didn't get.
What is the advantage of using the cuffed catheter, tunneled catheter over the ordinary jugular or subclavian?
It can be having longevity and prevent the infection, sir. It is.
You are talking about all sepsis.
No, sir. We are
Prevention
taking
of
into the
sepsis in
consideration.
per catheter.
We are approaching the patients in different approaches by ultrasound, checking the patencies and giving prophylactic antibiotics to prevent the catheter-related infection.
Speaking, you ultrasound guided
Yes, sir.
to avoid any unnecessary complications.
Not, sir. But puncturing and checking the vessel patencies, we are using ultrasound guidance, sir. Without knowing
For
vessel,
ultrasound guidance, you are checking the patency, not by just withdrawing the blood through the catheter.
that is also by puncturing in single shot to prevent multiple punches and preventing the collapsing of the veins and any hematoma creation.
So you told that it is the last option for all exhausted access site.
Yes, sir.
Why?
Because all AV fistula, what are the AV fistulas done were exhausted, sir, all got thrombos. This is the only last longevity. Next is the peritoneal dialysis.
You told that artless jugular catheter more prone for central vein thrombosis and stenosis.
IJV
So might
catheter,
have
sir.
in that patient had that options also. Then how do you select the site?
Most commonly, we will use right IJV, sir, because it is having a straight to the.
Right IJV is already exhausted. No? First, immediately any complication, they'll put the catheter into the right IJV.
Yes, sir.
Then you told all the sepsis are all complication very common with IJV catheter.
Yes, sir.
Then already screwed, no? Right is a jugular system.
Yes, sir.
And they innominate. Then how will you use that? Where will you go again?
We will go to the femoral,
That's
sir.
my opinion, I am telling you. It's not the last option.
Okay,
Even
sir.
the first option.
Yes, sir. Last option, short gap, which is having less time for fistula dialysis.
I am telling you,
Yes, sir.
the perm cath is better than the normal jugular ordinary catheter. Can you accept that?
Yes, sir.
I said,
Yes, sir.
first option.
Yes, sir.
You just basically simply tell that what is the frequency of the probe which is used for the ultrasound purpose? How much frequency of the probe is there?
Frequency.
Frequency, sir. Around we will use 15, sir.
50.
15 heads.
When the frequency increase, what is the problem? When the frequency decrease, what is the problem? When will you use the lower frequency? When will you use the higher frequency? For FCS.
Yes, sir. Don't know,
To
sir.
do an abdominal ultrasound, what frequency do you use?
Low.
What is frequency? What frequency?
For abdominal, we use low frequency, sir.
Deeper the vessel.
Deeper the vessel, low frequency.
For superficial, you want to see for the radial artery and the cephalic vein.
Yes, sir.
Then what frequency you are going to use?
High frequency, sir.
How much is that high frequency?
Have you seen the ultrasound?
Yes, sir.
They will have 3 probes.
Yes, sir.
Have you seen that how much the frequency?
It's 5 to 10, 1.
Your boss asked you to do some vein mapping.
Yes.
Frequency used.
We will use 5 to 10 we will use, sir.
7.5 to 10 if you say it is okay.
Yes.
10 is for the endo ultrasound. If you're doing the endo ultrasound, then the 15 is for that purpose.
Yes, sir.
Now, do you give this patient a prophylactic thromboprophylaxis when you're creating it?
Yes, sir. We will give, sir.
No, you're giving only heparin locally and also you're giving the prophylactic.
Prophylactic in hospital stay, we will give Clexane, sir. How long? For 3 days we will give, sir. And we will give antibiotic prophylactic for 3 to 5 days, sir.
What is that? Antibiotic prophylaxis? Which drug you are going to use? The
We are using ticoplanin, sir. And depending upon blood culture also, we'll select the antibiotics. Yes, sir. Bleeding, sir. Sir. It will increase, sir. Yes, sir. It will increase. Yes, sir.
And giving Clexane also is not advised.
Okay, sir. Better. Thank you, sir.
The next speaker is Dr. Sohail. He'll be presenting an online recorded session. He is available online. End of the session, he'll be available for 2 minutes to take questions.
Good morning. I am Sohail Naguib, vascular surgeon from Alexandria, Egypt. It's a great honor for me today to be presenting the microwave varicose veins treatment, the early Egyptian experience. I have no disclosures. As you all know, incompetence of saphenofemoral junction is the most common cause of varicose veins, about 75%. And NICE guidelines recommend thermal ablation as the first line of treatment of varicose veins. Microwave ablation has all the advantages of radiofrequency ablation and the latest laser fibers. In addition, it doesn't become in contact with the vein wall and act on the watershed. The first case was done by Professor Whitley, 2019, and we started our series 6 months later. In our study, we aim to prove the safety and efficacy of microwave catheter ablation in treatment of varicose veins. We had 10 patients admitted to Royal Vascular Center in Alexandria from August 19 till December 19. A prospective study with primary varicose veins C2, C5 of great saphenous vein, treated by microwave ablation, ultrasound guided using ambulant amount of tumescent anesthesia. All patients had clinical examination, duplex evaluation, informed medical consent. Our primary endpoint was anatomic and clinical success at 1 year follow-up, and secondary endpoint was technical success. We had follow-up 1 day, 1 month, and 1 year. We excluded patients with high or history of DVT, recurrent varicose veins, unable to perform the consent, less than 18 years, patient with saphenous refluxing anterior accessory or posterior accessory vein, and pregnant females. All patients were treated by microwave catheter flushed to the saphenofemoral junction with tumescent anesthesia, ultrasound guided. We started the procedure with puncture at the knee level, and we introduced our catheter till the saphenofemoral junction, as you see in the picture, flushed to the common femoral vein, and then we put the tumescent anesthesia, and then we started firing and pulling back the catheter. Our patient demography ranged about 35 years with almost equal male to female ratio. We had left side dominance in 6 patients and bilateral in 3 patients. We had significant decrease in all measures of the limb girth after 1 month with significant p-value less than 0.005. The preoperative Duplex data with great saphenous vein average 11.4 from 19 to 14, and duration of reflux was 0.5 to 0.7 seconds. Absent post-operative duplex reflux were on all patients 1 day, 1 month, and 1 year follow-up. Return to work was 2 to 5 days. The pain scale dropped from 7 to 9 to 1 to 3 in 1 month follow-up and almost 0 after 1 year follow-up. Post-operative pain was very mild, that was relieved with mild oral analgesics. VCSS score had significant decrease with p-value 0.01. We had no major or minor complication. Before we conclude, we have to know why we should use microwave, because it's effective technique with neither anatomical nor technical recurrence after 1 year. Bigger diameters of veins could be done with microwave. It is more safe as we are working at the lowest temperature of all thermal ablation technology, no forward propagation of thermal energy, malleable catheters that can negotiate curved anatomy of the veins. It's also cost-effective catheter, cheap, limited time procedure, minimal immediate post-operative pain and quick recovery, and early comeback to work. So to conclude, Mr. Chairman, dear professors and colleagues, microwave catheter ablation is a safe and effective method in treatment of varicose veins with expected lower recurrence rate and fewer complications than laser or radiofrequency ablation of varicose veins. Thanks a lot and looking forward to see you next year with a new topic and new research. Regards from Egypt.
Thank you. So you
Dr. Sohail is Dr. Khanna from Varanasi, India. Can you just tell that why did you exclude the C6 disease in your patients?
Hello, do you hear me?
You have included only up to C5. So why did you exclude C6?
We didn't have, at the time of the examination, C6 patient, so we didn't put the C6 patient that came later than the expected time for the procedures, because we wanted to have equal chances for all the patients.
Okay. Then you are putting your catheter first to the saphenofemoral junction.
Yes.
You know, when we are doing the laser or when we are doing the radio frequency, we keep it about 2 centimeter distal to that. So is there any chance of having the E hit in your patients?
Actually, we are now, regarding the laser ablation, we are using the double-ringed laser fiber catheter. So we are not anymore staying away for 2 centimeters from the saphenofemoral junction. We are using the crossectomy technique to minimize the recurrence rate, and it's effective. And we didn't have any E-hit patients either in the laser ablation or in the microwave ablation.
Thank you.
You're welcome anytime.
What is the duration you take for each procedure? Duration.
It takes about 30 to 40 minutes.
thank you.
Thank you,
You're
sir.
welcome.
Thank you, Dr. Sohail.
It's a great honor for me to be with you today, and I'm having a great honor. Thanks a lot.
Thank you. Now I invite the next speaker, Dr. Sharat Rajkumar, to give his presentation.
Good morning, sir. I am Dr. Sharath from Stanley Medical College. I'll be presenting about a rare case, which is globus jugular tumor. Next slide. Oh. Glomus jugular is a rare, slow-growing neuroendocrine paraganglioma that arises from the jugular foramen. It can have a wide range of locations, including the carotid bifurcation. Commonly, we see as the carotid body tumor. It can be at the superior or the inferior vagal ganglion, known as a glomus jugular tumor. At the auricular branch, it's called as a glomus tympanicum tumor. Incidence is pretty rare, 1 in 100,000 people, 1 to 3 per 100,000 people. So here we present a 31-year-old male who presented to the ENT department initially and was referred here for further management. He gave a history of slow growing swelling over the right side of neck for the past 1 year and inability to close the right eyelid and deviation of tongue to the right side for the past 6 months. On examination, it was an 8 into 8 cross soft compressible non-pulsatile swelling present in the right carotid triangle. It did not have any thrill or bruit. Carotid pulsations was palpable. Going on to investigations, patients, the tumor was investigated to see if it was a functional or non-functional tumor with 24-hour urine metanephrine, which was turned to be negative. We went ahead with a CT angio, which showed a highly vascular tumor with multiple feeders from the internal maxillary and ascending pharyngeal. And an MRI also showed a ill-defined hyperintense lesion in the right jugular foramen showing multiple floor voids and also had destruction of the temporal bone. The right internal carotid artery was encased. So since the tumor was highly vascular, we had planned for a preoperative embolization. The patient was underwent preoperative embolization with gel foam via the right femoral, and the targeted vessels, which was the ascending pharyngeal and the internal maxillary, was targeted, and pre-op embolization was carried out. In prop, the patient was painted and draped as we do for a carotid body, and controls of the carotid and IJV was taken. On further dissection, we found that the tumor was infiltrating into the IJV lumen. The carotid artery was dissected away from the tumor, and the tumor along with the lumen of the IJV was dissected. Post-operative period for this patient was uneventful. There was no further neurological deficit apart from the ones which he already had. The histopathology came out as a benign paraganglioma without any lymph node involvement. Patient has been discharged on further follow-up to image him again to see for the middle ear lesion. On discussion, glomus tumor is a very uncommon tumor found at the jugular foramen, usually at the origin of the jugular foramen. Compressive effects can cause cranial nerve damage. The most common symptoms are hearing loss, pulsatile tinnitus, and facial palsy, which our patient had. This tumor is usually diagnosed on the basis of radiological tests like a computer tomography or an MRI. Tumor depends on the size of the tumor. Small tumor, either you can leave it alone and observe, or you can treat it with the radiotherapy. Surgical treatment is usually preferred for a larger tumor with which has compressive features, or you can have a combination of both, which is planned for our patient. So we initially went for a excision and then planning for a radiotherapy on follow-up. Thing which helped us a lot was preoperative embolization of the tumor, which led to a decrease in the vascularity of the tumor, also a reduction in expected postoperative blood loss.
What about histopathology?
Histopathology, they just gave it as a
Paraganglioma.
sir. They haven't specified what type.
The radiological and the histological findings are not correlating. Paraganglioma is in an entirely different entity. How do you explain? Moreover, it is destroyed. The tumor has destroyed on the temporal bone. How could you removed it in toto?
The middle ear part is still pending. It's part of like a dumbbell-shaped tumor. A little bit of the middle ear part is pending. Planning for radiotherapy for that.
Paraganglioma infiltrating jugular is very uncommon. You didn't discuss with pathologists.
We discussed with. They said they doesn't have any features of malignancy.
How could the paraganglioma compress it?
Get the slide and send it to someone else.
What are the other places where you can have the glomus tumor?
Yeah, the bifurcation of the carotid, sir, carotid body tumor.
Yes.
In the around the jugular foramen, sir. In the middle ear
Apart
cavity.
from the neck.
Neck.
Where
Apart
else
from
can
neck,
it?
where you can get glomus tumor?
Internal auditory meatus in the middle ear cavity, sir.
You
Leaving
are
the
always
head,
head and neck, man. You
leaving
come-
the head and neck. Yeah.
Leaving suprarenal adrenal tumors. Pancreatic, retroperitoneal pancreatic.
Did you classify your case by the Shamlin classification?
Shamlin only class 3, sir. Encasing the carotids also.
Where did your patient fit? The Shamlin classification.
Class 3, sir. Class 3.
Can you tell one sign a tumor in the carotid triangle is there, and you say it is not a lymph node, it is not a bronchocyst, but it is a carotid body tumor or a paraganglioma? What is that sign? Clinical sign.
Clinical. Does not move with deglutition.
Nothing will move with the deglutition here.
The
So,
movements,
you know, if the lymph node is there in this area, it will have,
both anterior, posterior, and lateral move.
so it will vertically.
Vertically and
transfer to
horizontally.
move. But this tumor will,
Have only horizontal.
yeah, it will not move vertically. It can move transversely, but not vertically.
You did this therapeutic embolization. How? After therapeutic embolization, when did you plan to move it?
We did it 24 hours prior.
What material used?
This is gel foam what we use. Gel foam.
What are the advantages of therapy? One is it reduces the blood flow. What is the other advantage?
Maximum how many days you can wait?
24 to 72 hours is recommended.
For what? Why you are waiting?
Because one is it will recruit more collaterals. The other one is it will cause
More than
additions.
70 days, that's good.
Additions.
You get a good surgical plane.
See, reduce, then it will produce inflammatory reaction.
Inflammatory.
Surgical pain will be easy.
What was the feeding vessel here? Where did you
Ascending
embolize?
pharyngeal. Sir.
Hmm?
Ascending pharyngeal and
Ascending
internal.
pharyngeal was the feeding vessel.
Thank you, thank you.
Thank you, Dr. Sharad. I request the next speaker, Dr. Suhas Gowda, to go on stage.
Good morning, everyone. I'm Dr. Suhas, PG resident from MMC Institute of Vascular Surgery. I'll be presenting a case report on a patient with central vein stenosis with failed endovascular options managed with extra-anatomical vein-to-vein bypass. As we know, central vein stenosis is one of the most commonly occurring complications with patients in a functioning fistula, and prolonged duration of central vein catheter placement, insertion of peripherally inserted catheters, pacemaker wire insertion are all well-recognized risk factors for development of central vein stenosis. And it can lead to debilitating edema of arm, neck, and the face, and can also lead to increased duration of HD and also prolonged duration of bleeding after decannulation. And percutaneous interventions are the first choice of treatment, but they are associated with high rates of re-occlusion and re-stenosis. And even though we have high technical success rate with the percutaneous intervention, there are occasions where the lesions cannot be closed with conventional endovascular techniques. And ligation of the fistula is one of the most definitive but a drastic surgical option. This results in a loss of a functioning fistula for the patient and also doesn't address the problem of the central vein stenosis per se. So here we present a case report of a patient with a long segment central vein stenosis. He had failed endovascular therapy and we had managed with extra-anatomical vein-to-vein bypass. So our patient was a 48-year-old male patient. He had been on HD for the last 8 years. He had history of multiple failed fistulas. He also had history of multiple central line insertions in all the neck veins. Also, a perm cath was inserted in the right IJV. Patient had undergone left brachiobasilic fistula with primary transposition in August of 2021, and he developed a gradually progressive swelling of the upper limb following surgery. And the patient continued to get HD to the same fistula, and he presented to us 3 months after the onset of symptoms. And he had underwent a procedure at the outside center for the correction of the upper limb symptoms, but the procedure could not be completed as the wire could not be crossed. On examination, he had diffuse edema of the upper limb, face, multiple dilated veins over the chest wall on the left side of the neck. There is a palpable thrill noted over the left brachiobasilic fistula, and he had normal distal pulses. There was a significant difference in the mid-arm and the forearm circumference. We also noted an oblique scar in the left flank region, and examination of bilateral lower limbs was unremarkable. In this picture, we can see left side hemifacial swelling. The other picture, we can see the edema of the upper limb, also dilated veins over the abdominal chest wall and the dilated neck veins. So our CT venogram showed functioning left brachiobasilic fistula, also showed long segment occlusion of left brachiocephalic vein, which involved the confluence of the internal jugular vein and extend up to the superior vena cava. There was also a long segment of the right side brachiocephalic vein, which was noted. Venous duplex study of bilateral lower limbs was normal. So we took the patient up for an extra-anatomical vein-to-vein bypass after cardiac assessment and nephrology clearance. So we took control of axillary vein in the axilla, and through groin dissection, we took control of left common femoral vein. We did a subcutaneous tunneling from axilla to groin, and we completed the vein-to-vein bypass using a 18-80 PTFE graft bypass, PTFE graft. Post-operatively, patient had a significant reduction in the facial swelling and the upper limb edema, and he was able to undergo HT through the same fistula on post-operative day 2, and the patient was discharged with tablet aspirin. So coming to the discussion, in India, majority of the patients are started on a renal replacement therapy by insertion of uncuffed catheters. And this is a risk factor for development of central vein stenosis in most of the patient. Fibrotic reaction due to repeated punctures, delayed catheter removal, hematoma from the puncture site, and reactive fibroplasia due to vibration of the central vein catheter inside the lumen of the vein. They're all identified to be the pathophysiological risk factors. Surgical options are considered as second line of therapy, especially after recurrent stenosis or failed attempts at crossing the lesion. And extra-anatomical bypass, various options are available depending on the patent vein available for the outflow. Ipsilateral IJV or contralateral IJV can be used. Extrajugular vein, innominate vein, and superior vena cava, and even the right atrium have been used for extra-anatomical bypass. In the lower limb, we have option of using saphenous vein or the femoral vein. We have multiple case series which have demonstrated a good patency rates ranging from 87 to 50% at the end of 1 year with no significant surgical mortality. And patients were able to continue to use the fistula for a mean duration of 197 days after this extra-anatomical bypass without any need for intervention. And less than 10% of the patient had graft infection. So to conclude, in patients who have exhausted all endovascular options, axillary to femoral vein bypass it represents a unique and relatively safe approach, not only to alleviate the symptoms, but also to preserve the fistula. And further studies with larger samples or probably randomization are required to demonstrate longer patency rates and complications. Thank you, sir.
You assess the right opposite limb venous system.
Yes, sir. CT venogram also showed a long segment stenosis of the right brachiocephalic veins.
Right.
Yes, sir.
This is left side.
This is left side, sir.
Do you think the PTF is a good option for carrying out the venovenous bypass?
Sir, all the studies they have quoted, they've used ringed PTFE graft, but our center it was not available, so we used PTFE graft.
How do you score between the PTF and the vein graft?
So there are no comparable studies, but probably a vein graft.
Like when we are doing the infrainguinal bypasses, we always
prefer the vein graft.
use the vein.
Yes, sir. Yes, sir. Yes, sir.
Yeah.
But this is a long segment bypass, and such good quality of the vein might not be available.
Even you
The
are,
long saphenous vein from the opposite side. You get a very long vein.
Yes, sir. But we did the bypass to the femoral vein, so we wanted to keep the venous outflow of the leg intact.
The opposite.
Opposite vein.
what is the disadvantage of using vein conduit from
It
the
is
axle of
prone for compression and prone for neointimal hyperplasia.
even the plain PTFE is not you have to support a ring.
Ring PTFE, yes.
You should ask the patient to avoid lie on that side.
Yes, sir.
Put him on any oral antibiotic.
He's only on tablet aspirin, sir.
Check the coagulation.
Sir, he's
How often you are checking the patterns?
sir, every time he's coming for dialysis, he visits our OPD every 2 weeks or so, sir.
It is a failed cannulation in the outside.
Yes, sir.
Why didn't you attempt the intravenous?
Sir, the CT showed a long segment.
Why not?
We could have attempted, but
You know, plastic.
I said, but previously it was attempted elsewhere, and it's
Still you have the choice of weakness.
patient wanted one short surgery.
In another, what prompted you to do the surgery? You are a vascular surgeon, I think. Not the
Sir,
endovascular.
we could have given that a trial, but patient wanted one short surgery for the clearance of the problem. He couldn't travel that often, so we opted one for this one, sir.
Have you seen the patient plasty or standing after the central vein pace? Immediately they will have the immediate traumatic relief. The face will become normal.
Yes, sir.
But your patient is not like this.
Our patient
That's
also,
why I'm asking the patency.
sir, the surgery was,
Even in the arterial axillobifemoral have the lower patency rate.
yes,
You are
sir.
doing it in the venous side.
Yes, sir.
How could you expect the patency rate?
So the 3 case series, it is around 50% at the end of 1 year, sir.
Why not disconnect the AV fistula? You'll go for some other option.
Sir, this is a last option, so brachiobasilic fistula with primary
You
transposition.
want to only do ICD, not the peritoneal dialysis.
If this also fails, that will be our next option, sir.
Why not now? When you are going for the rare option?
Because the rare option is going to give him another 1 or 2 years.
Common option, ambulatory.
Sir, with this rare option, also,
peritoneal procedure.
sir, with this,
I ask the patient to it is available in all government hospitals free of cost.
yes, sir, but this gives him additional 2 years of functioning fistula.
When there is a straightforward approach, why you are going for a complicated?
That is always available for the end stage, sir. So,
Simple, straightforward procedure is the priority, not the complicated.
yes, sir. Relief of symptoms as well, sir.
You disconnect. Thank you.
Thank you, sir.
Same case comes with bypass. Doesn't work very good.
Thank you, Dr. Suhas. Next, I invite Dr. Hari Kamal for his presentation. I encourage all delegates on the floor to question the presenter.
Good morning, sir. I am Dr. Hari Kamal, vascular surgery resident in Ramaya Medical College. Today I will discuss about evaluation of patency in post-access angioplasty in chronic kidney disease patient. My aim is to study the patency rate and long-term results of central venous and anosmotic site stenosis treated with the endovascular approach in our center over a period of 4 years. Chronic venous hypertension is a debilitating illness, not only because of signs and symptoms, but it causes a losing of, we are losing access in hemodialysis patients. The leading cause of failure of AV access is venous anosmotic stenosis and central venous stenosis. The causative factors are punctures, cannulation, and hyperdynamic circulation accompanied by complex mismatch and turbulence in the central vein. Although endovascular and open procedure are used for the treatment of stenosis, neither has accepted as a treatment of care, and no therapy is proved to be effective. So endovascular intervention is have become the treatment of choice with angioplasty with or without stenting. This is an observational single center study in our center. The presenting symptoms varied from inadequate dialysis and excessive post-dialysis bleeding time and dilated veins over the chest and upper limb And also patients were present with thrombotic, thrombosed AV fistulas and AV grafts within 14 days of inadequate or unable to perform hemodialysis. A total of 66 patients were studied for the treatment period of 48 months between August 2017 to August 2021. The most of the age group is between 51 and 60 years in our study, and most of the population is male predominant, and the main axis type was treated was AV fistula. Inadequate dialysis and thrombosed AV grafts are the most common presenting symptoms. The others are puncture site bleeding and limb swelling and dilated veins over the chest and limbs were treated. The most common site of stenosis was brachiocephalic, followed by venous end of anastomosis and axillary vein puncture vein stenosis. 66% of our study group were at the stage of failing axis, and the other group was with no flow or a thrombosed AV graft, and 7 of our study group with the normal flow. We treated 51 central vein patients, among which 31 were brachiocephalic and 15 were axillary and 5 were subclavian, in which 6 were bare metal stents were put in the innominate vein, and primary angioplasty was performed in 60 patients and stenting was done in 6 patients. And in AV graft thrombosis patient, we initially done thrombectomy, and later we addressed the underlying cause like stenosis with angioplasty. In some cases, in 6 patients, we have done stenting. Both autogenous axis and prosthetic AV grafts were used after the next day, immediately after the procedure. And there is significant reduction seen in the patients within 48 hours of the procedure. And patients were advised with compression dressing, compression bandage with to reduce limb edema, and also we have covered with prophylactic antibiotics. And we followed the patients at 3rd month, 6 month, and 12-month period. The primary patency at the end of 12 months was 60% in our study. Reintervention was done in 90.6% of patients who have thrombosed AV fistulas and persistent limb swelling. And ligation was done in 8 of the patients who, because of persistent venous hypertension and with the total occlusion of the subclavian veins. At the end of 12 months, most of the patients who underwent our salvage procedure have undergoing dialysis, and we did not encountered any procedure-related complications. And we know that central vein stenosis and venous end anastomosis stenosis and axis stenosis is very important for the long-term dependent hemodialysis patients, because axis is very important for the dialysis in chronic kidney disease patients. The primary pathology was the catheter-induced trauma, which leads to inflammation and which is causing intimal hyperplasia, which leads to development of fibrosis and stenosis in the central veins. Symptoms varied from the upper limb edema and post-dialysis bleeding, prolonged bleeding, and hyperpigmentation in the and causing due to stenosis in the subclavian veins. The mainstay of the treatment is endovascular, in options being angioplasty with or without stents. KDOQI guidelines recommend PTA with or without stent placement as a preferred treatment approach. To conclude, endovascular treatment is the with angioplasty with or without stenting is the safe and low rates of failure is seen in the patients who underwent this procedure. Only angioplasty without stenting is by far the preferred approach, since it is less invasive and more highly repeatable. These are my references. Thank you.
So you failed to cannulate, then what will you do? Same question. Previous presenter straight away gone for bypass. You told the priority is endovascular. If you are not able to cannulate, you are not going through that stenosis, what will be your next option?
We use the opposite limb approach, or else radial artery puncture we can use.
You are not understanding my question.
Sir.
So the central vein stenosis, you are not able to negotiate through.
Yes, sir.
So you cannot always success.
Yes, sir. Yes, sir.
Success in negotiating through the lesion. So acceptance is the first priority.
Yes.
If it is not there, say have you encountered any failure? You are 100% success.
No, sir. One patient we have feel difficulty to
Dimension.
I mean, through the same puncture, but opposite we have done.
When will you consider the patient for stenting?
Residual stenosis, sir. Even after repeated angioplasty, if there is residual stenosis, we will do stenting, sir.
Repeated stenosis.
Repeated angioplasty.
Repeated stenosis after angioplasty is the dictum. The patient will come 3 to 6 months with stenosis. You would again dilate.
Yes.
What is the main disadvantage of placing a stent in the central vein?
Disadvantage. Thrombosis.
If it is fractured, it is collapsed. Over. Your chapter close. This angioplasty, you can repeat always.
Yes.
The first time you will have a little bit difficulty, but the second time you can easily pass the wire.
Yes, sir.
Just dilate and send the patient. Stenting is the end point.
Yes.
The more proper complications.
Yes.
You are using the metal stent. So
Yes.
not like the arterial.
Yes, sir. Yes.
Venous is fibrotic.
Fibrotic, sir.
It
Yes.
will compress.
What is the cause of hyperpigmentation?
Mm.
What's the cause of hyperpigmentation in varicose vein?
Venous insufficient. Venous
Venous hypertension.
hypertension. Yes, sir. Venous.
Which year you are studying?
Second is
And you have to punish.
Thank you, Dr. Harikamal. Next, we have a recorded online presentation by Dr. Karthik Datta.
Good morning. I'm going to present our data from a retrospective of study of catheter-directed thrombolysis in acute deep vein thrombosis. The aim of this study is to evaluate the safety and efficacy of catheter-directed thrombolysis and to identify relevant patterns. There are 12 patients from were included in this study. The study was done during the period of July 2017 to July 2021. The data from these patients was retrospectively analyzed. There were 8 male patients and 4 female with mean age of 46 years, the range being 27 to 60. The mean duration after symptom onset was 5.66 days, the range being 1 to 14 days. And so the symptomatic side was the left in majority of the patients, 83% of the patients, and it was the right side in 17% of the patients. It was primary DVT in 10 patients, and it was recurrent in 2 patients. The majority of the patients had a provoked etiology for the DVT, that is 60% nearly, and 40% had an unprovoked etiology. For all the patients, iliofemoral segment was involved, and proximal extent progressed to involve the IVC in 2 patients. 4 patients, that is 33%, had symptomatic pulmonary embolism, and for 4 patients, that is 33%, IVC filter was placed before initiation of CDT. For 3 patients, the indication was development of pulmonary embolism despite anticoagulation. And for 1 patient, the indication was severe anemia, not allowing to adequately anticoagulate. The lytic agents used were recombinant streptokinase, recombinant urokinase, and reteplase. The dose of lytic agents, both recombinant streptokinase and recombinant urokinase were given at a minimum of 30,000 units per hour and up to a maximum of 90,000 units per hour. The mean duration of lysis was 37 hours, the range being 24 to 48 hours, and 500 units per hour. Heparin was given through the sheath. This was the standard dose, and it wasn't changed for any patient. Technical success defined as at least partial recanalization of the inward segment on check venogram was 100%, and clinical response defined as decreased in limb circumference was also 100%. Bleeding manifestations occurred in 3 patients, that is 25%, and mean time to onset of bleeding was 32 hours, the range being 24 to 38 hours. The plasma fibrinogen level at which bleeding manifestations occurred was mean of 75 mg per dl, the range being 58 to 79. All the bleeding manifestations were minor, with that being scrotal, one patient having a scrotal hematoma and 2 patients having arm hematoma due to bleed from IV puncture sites. Drawing from the data, we can say that the CDT is a safe procedure with no major or life-threatening bleeding. The caveat being that all patients were closely monitored, at least second hourly, for bleeding manifestations because they were in the ICU. The limitations of this study is that small sample size and the descriptive nature and lack of a comparison group. Larger studies are needed in this regard. Thank you.
Thank you, Karthik. Two questions for you. Did you measure the serum fibrinogen level before initiation of lytic therapy and post-lysis? And
before any,
yeah.
sir, before initiation of the therapy, baseline was obtained, sir.
Yeah.
After
You
the therapy, we
mentioned
didn't measure, sir.
You didn't mention it. And second thing is, the dose of streptokinase is different from dose of urokinase, is it not? You are given the same dose for both.
Yes, sir, we were using the dilution was different.
I
sir,
know
and-
urokinase dose is correct, but streptokinase dose you have to go and check up. It's not the dose what you are talking about. What is the dose of you used? What is the third agent you used? Altiplase or Retiplase?
Retiplase, sir. It was used
What is
only
the
for one
dosage?
patient.
How much you? What is the initial dose and maintenance dose?
0.75 units per hour, sir. Maintenance dose to maximum of 20 units.
What's the advantage of Retiplase over these things?
Not aware.
Advantage of Retiplase over urokinase.
No allergic reactions, sir.
It's not like that. Not like that. Please check up.
You said, Karthik, that there was decrease in the limb circumference. What is that decrease? 5%, 10%, 50%?
We haven't measured it. We haven't quantified it.
It has to be quantified. You just cannot say that it is decreases there. And in your unprovoked cases, did you carry out the thrombophilia profile?
No, sir, it wasn't carried out for any patients, sir. Mostly they are poor patients in this setup, sir.
So if you have to do a thrombophilia profile in an unprovoked DVT, when you will do that?
At least 6 weeks after stopping anticoagulation, sir.
And what was your follow protocol for these patients after you have done the CDT? How did you follow up these patients? With what drugs?
Anticoagulation was given for minimum of
Which one and how long?
Initially, we were using Acetrom, sir. Acetrom, dose titrated Acetrom we were using, sir. Since 1 year, we have been using the newer anticoagulant, sir. Rivaroxaban mostly, sir. 15 mg BD followed by 20 mg.
Duration of that?
Sir, 3 months, sir. 3 months afterwards, we were taking the repeat venous Doppler and D-dimer, sir.
So whether it is provoked or unprovoked, in both cases, you will give 3 months?
In unprovoked, we would prefer to give 6 months, sir, but 3 months we were routinely once checking, sir.
Okay.
So you know the dose you have given for streptokinase, urokinase, and Retiplase. So straight away give the same amount, 90,000 units per hour, or you will give some loading dose?
Sir, loading dose, streptokinase we were giving 5 lakhs units, sir, through the
5
catheter.
lakhs?
Yes, sir, 5 lakhs we were giving, sir. Urokinase we were giving 1 lakh units, sir.
Why you are giving 5 lakhs in streptokinase?
Which is the standard.
What is the main disadvantage of streptokinase?
Yeah, recombinant streptokinase we were using, sir. The main disadvantage, hypersensitivity reaction, sir. And if it was given in the past, lack of response will be there, sir.
Produce
In
antibody.
the past 2 years.
You produce antibody.
Yes, sir.
Why you are giving loading dose streptokinase? Now tell.
To overcome the resistance. And to overcome the antibody.
Neutralize the existing
Neutralize.
streptococcus, no? Streptococcus infection without dystonia, no human will be there. So you neutralize the antibody, you give the loading dose. So what he asked, what is advantage of streptokinase urokinase reticulase cytoplasminogen activator over the urokinase streptokinase?
So there are no antibodies. There is no resistance.
It's a specific thrombin specific. Okay, thank you.
Oh, thank you.
Thank you, Dr. Karthik. The next presentation is by Dr. Sanjeeva Rao.
Good morning, everyone. Good morning, friends, and good morning, judges. I'm going to present a case of hybrid removal of an perforated IVC filter, which is a rare complication. A patient presented with us with 63-year-old male, post-COVID patient, posted for IVC filter retrieved by one of the senior cardiologists. But during the procedure, IVC filter got stuck. And he tried with the snaring with the other snare also. That snare wire also got entangled and it got completely broke and attached to the IVC filter barbs. And after trying 2 hours, he called me for help in the cath lab. I entered the cath lab, seeing the image. I got the doubt that it is not in the IVC, sir. I think it is migrated somewhere else. Better we will see, go for a CT scan and evaluate it. And we got a check shot. There's little leak from this thing IVC. You can see the image. It is entirely, the filter is entirely deviated from the IVC, and there is also entangled snare wire which he tried before. This is the picture when I entered in the cath lab. So immediately I told it is somewhere it is migrated, sir, not it's the natural anatomy. So we did a CT scan immediately, and it showed like the filter hook is perforating the duodenum. So immediately we took into the theater. The plan was initially to retrieve the filter by exposing the IVC, see the situation, and then retrieving when plus or minus close with the patch closure. When I sorry. So midline incision was given. I had an idea of doing it in a hybrid technique also. I searched the literature. So there was only one paper which was published before. So with some idea, I kept all the things ready to in the theater. Under CRN guidance only, I proceeded. So initially, with the upper midline incision, I could expose the IVC by just mobilizing the duodenum. Then clearly we can see the hook, that is the IVC hook, which is coming out and perforating the abutting the duodenum. But the duodenum rent was very small, that we could initially do with a small primary repair. And seeing the hook, so I thought of going for the hybrid removal. So I took a purse string along the entry side from in the IVC, and how we snare from the from the jugular. So I put the snare to the hook, and then same technique with the CRN guidance. I try to retrieve with the our technique. Can you play the video? Other video. So thank you.
So same technique how we retrieve from the jugular, I retrieved with snaring the same thing, and immediately under CM guidance. After that, we have retrieved the snare wire and everything. After this, immediately we check with the CM also, and we close the primary filter, just IVC. And the recovery also, it's very fast, and the incision also, it's very just up to the umbilicus, and we can discharge the patient in 3 days, and now he's in follow-up also, he's doing well. This is a scarf. That is the IVC piece and everything. This is the scar photo. So to conclude, the placement of an IVC filter is a well-established management strategy from so long. There is exponential rise in IVC filter placement is associated with these days during increase in the interventions. At the same time, some sort of complications are also happening with the IVC filter. So I thought of a hybrid approach consisting of an open exposure of the vena cava and endovascular retrieval, with which may maximize the benefit for each procedure for complicated this retrievals also. And with these things, actually, we could save the morbid procedures, and we could help for the patients. This is the one paper presented in the literature from vascular by Elizabeth Vascular Journal in 2005.
So why you prefer to retrieve by jugular? You already opened the abdomen, exposed the IVC. Why not you will open the IVC and retrieve?
No, sir. Initially, the cardiologist tried directly by jugular, and he took that both axes.
No,
and
no,
he
I am asking, leave it to the past history.
Okay.
Present history, you are open. You expose the IVC.
Yes, sir.
You repaired the rent.
Yes, sir.
So you open the IVC and remove the IVC filter and close the rent. Why do you push inside and again?
No, not I didn't push inside, sir. I hooked the filter snare or outside only, and I pushed just the sheath. How we retrieve from the jugular, we push the sheath only. I didn't push the filter inside, and I didn't do these things. I kept there only and pushed the sheath. So the rent will be very small, like a sheath rent only, and we can close with the primary, or else complete. Yes, sir. We minimize injury and all patch plastic. We can avoid all those things.
IVC, no, there is no need
Yes,
for
sir.
any patch plastic.
If the big filter, no, sir. That's
How much filled that IVC in a normal pool? Only 1/3 of the capacity will be filled.
yes, sir.
So even you reduce it half 50%, nothing will happen.
Yes. So we thought of it is a minimal invasive this thing. Senor.
How much was the hemoperitoneum in your patient?
Not much, sir. Not of much. It's only I could hardly say 10 to 15 ml. That too, it's a contained in the duodenal and this space, sir. It was not like a severe oozy picture. It's not. Only the filter filter hook got perforated, and it's hitting the duodenum, sir.
How many layer closer?
The duodenum injury, it is gastro people. I took a gastro help, sir. They told we can directly close over single because it is not completely perforated. Only subserosa it is a damage. So we opted for that, and I kept NBM for 1 or 2 days. Observed the bowel salts are good and everything, so we discharged. And he still followed. Yes, sir. We cauterize the duodenum. And yes, sir. Yes, sir. Only the duodenal part we cauterize. These drain, they have asked for that, right?
What is done by Castander?
Yes.
The problem with the duodenal blowouts.
Yes, sir. Blowouts. Yes.
So usually we do the aortoenteric fistulas, no?
Yes, sir.
We keep the omental patch between
Yes, sir.
aortic repair and the That's what we want. We want it.
Yes.
It was not a disease.
Yes, yes.
Yes.
Thank you.
Thank you, sir.
Thank you, Dr. Sanjeev Rao. The next presentation is online by Dr. Bhavana Girdani.
Good morning, everyone. I am not able to share my screen.
You talk to, we are seeing you.
Okay. Good morning, everyone. I am Bhavna Girdani from Postgraduate Institute of Medical Education Research, Chandigarh, India. So, chronic venous diseases, as we all know, that ultrasound is the diagnostic modality of choice to look for the reflux patterns in this disease. However, it can also be used to see the fine morphological details of cutaneous as well as subcutaneous layers. But it is a very scarcely utilized resource to assess the skin changes. As in a study that was conducted by A.K. Gyati in 2016 to evaluate the utility of ultrasound for evaluating.
Share your slides.
Bhavana, can you share your slides?
Share your
screen.
slides here.
Yeah, that has been disabled.
No, there is a share screen option on the bottom.
Yeah, I am, but I think it has been disabled.
Did you open your PPT before
Yeah.
and then you logged in?
No. Is
fact,
it
you have to
visible?
open your, yeah,
Yes, now
it's
we
coming
can
now.
see.
Yeah, it's there now.
Can you start again?
Yeah, make it a
Thank you so
slideshow.
much. Yeah,
Make it a slideshow. Yeah, that's okay. Good.
thank you so much. So, good morning, everyone, again. As in, we all know that ultrasound is the diagnostic modality of choice to look for the reflux patterns in patients with chronic venous diseases. However, it can also be used to see the fine morphological details of cutaneous as well as subcutaneous layers, but it is a very scarcely utilized resource to assess the skin changes, which is mostly done clinically. So, as in a study that was conducted by A.K. Gyati in 2016 to see the utility of ultrasound for evaluating skin changes in CVD, it showed that it refines the clinical examination. The skin changes which are indistinct on inspection are visible, gives us a better grading of venous disease severity, and it helps us to stratify the treatment. So the aim of our study was to examine the skin changes in chronic venous diseases with ultrasonography to stratify various findings in different stages as per the CEAP classification, and also compare the changes with the normal skin of the same limb as well as the contralateral limb. It was a cross-sectional study conducted over a period of 18 months at our own Department of General Surgery, PGI MER, Chandigarh. So all the patients in the age of 18 to 85 who presented with chronic venous disease were included in this study. However, pregnant females, patients with congenital venous insufficiency or skin changes due to arterial occlusive diseases, any peripheral edema due to cardiovascular or renal causes were excluded from this study. So as in the patient walked in the clinic, after a thorough history, physical examination, and the local examination of legs, we classified the patient as per the CEAP classification, and then the ultrasound of the skin was performed, assessing the cutaneous layer, subcutaneous layer, the dermo-hypodermal junction, if presence of any dermal edema or any other significant findings, and it were compared with the normal skin of the same and the contralateral leg. So a total of 55 patients were examined, out of which 17 were females, and a total of 102 legs were included, out of which 44.1% belonged to the C2 category and 30.4% belonged to C4B. So among all the C2 patients, 22% had dermal edema, which was not present on physical examination, and inflammation of the cutaneous and subcutaneous layer was present in 8.9%, with loss of dermo-hypodermal junction in 6.7% of the patients. Of the total C3 patients, 33.3% had dermal edema and subcutaneous layer thickening, whereas 25% had anechoic lacunae. Of the total C4A patients, cutaneous layer and subcutaneous layer inflammatory phenomena was seen in 18.7%, whereas the disappearance of dermo-hypodermal junction was seen in 68.7% of the patients. Dermal or subcutaneous layer edema was found in 12.5%. In C4B patients, the dermal edema was present in 87% of the patients with disappearance of dermohypodermal junction in 93.5% of the patients. The hyperechogenic and thickened subcutaneous layer was seen in 54.8, with cutaneous layer thickening in 80.6, and change in the thickness or epidermal loss in 35.5% of the patients. Out of all the C5 and C6 patients, dermal edema or dermal and subcutaneous varicosities were seen in all the patients in addition to the other findings. So these are the two grayscale images. In first, it shows belonging to the C2 category patients. A shows that there is no significant change in the cutaneous layer, subcutaneous layer, or dermohypodermal junction, whereas B also belongs to a C2 patient, which shows that there is dermal edema. It shows that there is dermal edema with subcutaneous layer hyperechogenicity and anechoic lacunae surrounding. These are again the two grayscale images showing epidermal thickening, dermal edema, and subcutaneous layer hyperechogenicity in first image, and hypodermal edema with loss of dermohypodermal junction and subcutaneous layer hyperechogenicity in the second image. To conclude, ultrasonography may reveal skin changes even in the early stages of CVD that may appear normal on clinical examination. So ultrasonographic evaluation of the skin changes adds insight to the clinical assessment and grading, and it improves the understanding of idiopathogenesis of chronic venous diseases. Thank you so much for listening.
And also management, correct?
Yeah.
Bhavana, does it make any difference if it is a dark skin is there or a white skin is there? Does it make any difference in the ultrasound pictures?
With between the North Indian and North Indian leg and South Indian leg.
No, sir. Doesn't make any difference if the patient has whatever the pigmentation is there, but it does make a difference with the classification of CAFP.
And how does it help in your management?
So, sir, the patients who had C2 disease and had changes in the skin which were not apparent clinically, we would like to go ahead for their treatment before the other ones. So we can stratify who needs a management or a intervention before the other ones.
Thank you.
Thank you.
Thank you, sir.
Next, I invite Dr. Rutvij Shah to come up with this presentation.
Good morning to everyone present over here. I am Dr. Rutvij Shah, DNB trainee at Gangaram Hospital in Delhi, and I'll be presenting my study on thermal versus non-thermal endovenous ablation. Is the paradigm shifting? So the aims and the objectives of the study were to compare the two modalities, thermal and non-thermal. Thermal was the radio frequency ablation, and the non-thermal one being VenaSeal, that is endovenous glue ablation, in terms of vein occlusion rates, that is treatment success rates, and an improvement in VCSS scores. It was a single center study performed over a period of 2 years with 296 patients, 514 limbs evaluated at 3 and 6 months. The inclusion criteria was clinically and radiologically diagnosed varicose vein disease with truncal reflux, and the choice of modality was completely patient-based. Exclusions were standard tortuous target veins, diameter of the vein being more than 20, known sensitivity to adhesives, etc. Treatment success was defined as complete occlusion of the vein segment or a recanalization less than 5 centimeter evaluated on sonography. A subtotal recanalization was 5 to 10 centimeter vein segment, and a treatment failure was defined as a recanalized segment of the treated vein of more than 10 centimeter. And the VCSS score was measured according to the standard VCSS criteria. So we had two groups. The RFA group had 186 patients, 322 limbs, and the VenaSeal group had 110 patients, 192 limbs. The average age was 54 in the RFA, 44 in the VenaSeal group, and majority were males. Majority of the patients in both groups showed a C2, C3 disease, 78% in RFA and 89.6% in the VenaSeal And majority had both level incompetence, that is SFJ as well as SPJ junctional incompetence, 85.7% in the RFA group and 73.9% in the vena seal group, meaning we had to ablate GSV as well as SSV. So the average diameter of the GSV was similar in both the groups, 7.19 in the vena seal and 7.32 in the RFA group. And we did adjuvant procedures of sclerotherapy and phlebectomies along with the primary procedures. So majority of both the groups required adjuvant procedures. So the treatment success rates at 3 months in the vena seal group was 100%, and at 6 months was 96.8%. And in the RFA group of 322 limbs, it was 93.5% at 3 months and 90.75% at 6 months. So this is the vena seal group, which shows that there's 100% of vein occlusion rate at 3 months. And at 6 months, we had a treatment failure in 2 limbs, which is 1.1%, and subtotal recanalization in 4 limbs, 2.1%. And in the RFA group, at 3 months, we had 9 limbs showing 2.8% and 12 limbs showing 3.7% of failure and subtotal recanalization. Whereas at 6 months, we had 3.7 and 5.9% of treatment failure and subtotal recanalizations. On the comparison of closure rates of both the modalities on Farrington-Manning equivalence test, it showed that the newer modality of vena seal had non-inferiority with a 95% confidence interval and a p-value of less than 0.05. And on the Bayesian effects model and Kaplan-Meier plot analysis, vena seal showed higher probability of being the better out of the 2 modalities. 100% patients showed an improvement in the VCSS scores. Pre-op of 2.9 reduced to 0.34 in the RFA group, and pre-op of 2.5 reduced to 0.32 in the vena seal group. The complications in the RFA group were higher. Paresthesias were noted in 3.7%, and the phlebitis was noted in 4.9% of the patients. In the vena seal group, there were complications of skin allergy in two limbs, 1% population, and phlebitis in 4 limbs, 2.1% of the population. The average interesting outcome came from this study was that average length in the vena seal group was 89.1 centimeter average vein length per limb, and the average glue used was 2.95 ml per limb. And there were 8 cases where we had to use more than 5 ml of the glue, which is 5 ml is the provided by the companies. We had to use more than that. We had to open 2 kits instead of single kit. So in comparison with similar studies, there is a recently published just now Wilco study of 89 patients. There's another Canadian study comparing RFA versus glue ablation in 335 patients. V-close study of vena seal of the US, 222 patients. Saffion Hospital has published in 2019 a study of 222 veins. And there is a meta-analysis in 2020 published of 20 different RCTs. So on comparison of all these studies, we can infer that in all the studies, the outcome or the closure rates in the vena seal group are slightly more than the RFA group. It is, and with a significant difference in the Jasna Wilco study, 62 and 91%. Canadian study shows excellent results at 99 and 100% in both the groups. V-close is 91.9 and 94.4. Saffion has published 95.1 and 96.4 in RFA and glue closure, and our study shows 90.4 and 96.8 at 6 months. The meta-analysis published in 2022 states that out of 4,570 patients studied and compared for various modalities in terms of anatomical success, VCSS, etc., vena seal is likely to have the best outcomes with the least adverse side effects. It was published in the Journal of Vascular Surgery. So to conclude, non-thermal non-tumescent endovenous ablation is a newer effective modality with excellent treatment success rates and minimal complications. It is non-inferior to the thermal ablations with multiple advantages, and one of the biggest advantage being a possible option under local anesthesia and an OPD-based procedure. Thank you.
Any difference in the cost factor?
A lot of difference. Vena seal itself has an MRP of 90,000 rupees, the kit itself. And there were 8 cases where we had to open more than 2. So it means 1,80,000 just for that. And in RFA, the average cost is around 50,000-70,000.
So your study is thermal, non-thermal.
Thermal versus non-thermal.
Why?
So it's basically
what
RFA.
point you have RFA you preferred, not other modalities of thermal ablation.
Sir, I've taken retrospective data of the patients who have decided based on all the options they had. So
Not you can compare the laser or
Sir,
any other thermal ablation. Why RFA?
Sir, at our center, we usually do not perform laser. This thing we have shifted to RFA 4 or 5 years back. Only RFA is being done.
How did you randomize your patients between the RFA?
Sir, Sir, so randomization was completely OPD based. Patient had varicose vein diagnosed, and they were explained about treatment modalities, costs, outcomes, and based on what they decided, I entered them into my study.
Maybe that RFA you are taking the advanced C4, C5 disease, while here you are taking C2 disease.
No, sir. So I showed that statistic. We have both the modalities. Nearly 75 to 80% were C2, C3 disease in both the modalities.
2.5 ml you are using per limb.
Yes, sir. Yes, sir. On an average, 2.95 was the outcome. 2.95 ml.
ml per limb.
Per limb.
How will you inject? I cannot understand. Whole course.
Yes, sir. So
you are singly inject like IV.
No, sir.
Or
So how
with the catheter withdrawal?
Catheter withdrawal, sir. So how the VenaSeal works is that there is a injector gun with a catheter, and there is a there is a sheath, and from that a small 5 centimeter segment of catheter comes out from the sheath. You inject and then you withdraw the entire system by 3 centimeters. So you have to, and for every injection there is a gun. So it quantifies 0.1 ml injection per 1 shot. So while you give 1 shot, withdraw by 3 centimeters. So 0.1 ml is delivered. But if you have an accessory saphenous vein, or if you have a duplication of GSV where you need to inject more than 1 truncal veins, that glue is not sufficient. The glue provided in the VenaSeal seal.
That only vial is 90,000.
So the entire kit of the gun, the catheter, everything. And this glue technically is N-butyl cyanoacrylate, but the VenaSeal company has produced it that way that they have the trademark for it. It is not the same as the N-butyl we use in our endovascular cases.
So actually we can do only in Gangaram, not in
I don't know, sir.
Where do you keep the tip of the
5 centimeters from the saphenofemoral junctions.
And there you keep 2 centimeters.
2 centimeters, yes, sir.
So does that make any difference?
So there were a couple of studies where the tip initially, when VenaSeal came in, the glue ablation technique came into practice, the tip was kept only 2 centimeters. And they reported it as an extension of glue into the deep veins causing DVT. Significant amount of DVT was noted. Hence, they changed the protocol. VenaSeal advisory says that you keep 5 centimeters away.
Do you do any maneuver to prevent?
We compress the saphenofemoral junction with an ultrasound probe. Yes. Thank you, sir.
Dr. Bhumika, can you share your screen? Can you unmute yourself and then share your screen?
Yes, sir. Good morning, everyone. Am I audible?
Yes.
Good morning, everyone. I'm Dr. Bhumika, working at Fortis Hospital, Mohali. The topic of my presentation is long-term results of percutaneous transluminal angioplasty versus stenting in central venous obstruction in hemodialysis patients, and it is a single center experience. The aim is to compare the results of percutaneous transluminal angioplasty and stenting in CVO cases in terms of primary patency and assisted primary patency rates. So this is a retrospective analysis of hemodialysis patients who underwent the treatment from April 2016 to October 2021 at Fortis Hospital, Mohali. Patients with failing and failed AV fistulas with features of central venous obstruction were subjected to the treatment. Stenting was reserved in angioplasty-resistant obstruction and recurrent lesions, and self-expandable stents were applied. So we conducted the study on total of 89 patients, out of which 78 underwent angioplasty and 11 underwent stenting. The mean follow-up of patients was 18 months. 20 patients underwent re-intervention within the 12 months of follow-up period. Out of them, 17 underwent angioplasty and 3 underwent stenting. The main lesions we found were, the main culprit were at the brachiocephalic segments, and the SVCs were only 16.38%. We used antegrade approach in 84 cases and retrograde approach in 5 cases. We achieved technical success in 97.75% cases and had unsuccessful results in 2 patients. The primary patency rates of angioplasty at 3 and 6 months were 97.86 and 89.05%, and of stenting at 3 and 6 months were 95.43 and 88.65%. The assisted primary patency rates of angioplasty at 3 and 6 months are 90.50 and 86.35, and that of stenting at 3 and 6 months was 86.85 and 80.60. We have not seen any stent-related complications. These are the various images showing the percutaneous transluminal angioplasty, the central venous obstruction, which we are getting through with angioplasties. I'm sharing a short video of the stenting and post-stenting results. These are the various studies conducted overall throughout, and the latest in 2020 at Istanbul Hospital, showing good primary and assisted patency rates. In conclusion, the central venous obstruction can be safely and effectively managed with endovascular procedures to extend the life of AV fistulas. Percutaneous angioplasty is mainly done for primary occlusion of stenosis, while stenting is reserved for lesions which are non-amenable to angioplasty or recurrent stenosis of the treated segments. The latest being the drug-coated balloons, which are under studying, and the future is ahead. Thank you so much.
Dr. Bhumika, can you stop sharing your screen?
Yes, sir.
Dr. Bhumika, what complication you expect when you're doing this procedure?
So the main complication is unable to pass through the region, which is the technical aspect.
Not
and
the complication, that is a technical failure, isn't it?
Yes, sir.
Complications.
Sir, the angioplasty main will be rupture of the venous segments, which is most commonly seen. And other is stent-related complications, which is stent migration or stent fracture, which is also seen. But as of now, we have not seen such complications, sir.
You keep your patient on some prophylaxis or
Sir,
aspirin or any drugs?
Sir, we usually don't give any post-procedure. We usually give ecosprin 75%. That's all, sir. Intraoperatively, we give heparin around 4,000 units, and post-operatively ecosprin 75, sir.
Thank you.
Which approach you prefer, the femoral or you do the fistula?
Sir, we try the antegrade approach only, and have seen success in the antegrade approach also. And only in 5% cases we went through the groin, sir. Retrograde approach was used. So our main antegrade approach only, sir.
Okay, thank you. Thank you, Bhumika.
Thank you so much. Thank you. Thank you.
Now I invite Dr. Ratnashri Ravipati for the last presentation of the day. She's going to do it online. Dr. Ratnashri. Dr. Ratnashri, are you online? I think that brings us to the end of the doctor's free presentation. So I thank Dr. Jayakumar and Dr. Ajay Khanna for patiently chairing the session. Thank you all for attending. Now we'll go to the main hall to attend the oration. Thank you. Two more have not come. We are done.
Thank you, sir. I'm happy to serve you. You add